All right. Hello, everyone. Welcome to a new episode of the Embracing Joy podcast. I'm so excited for our guest today, who's Dr. Sarah Merritt, who's a pain specialist, and we're going to go over the topic about how pain and joy can coexist, can they? And we have expert in pain management, Dr. Sarah Merritt. I'll tell you a lot more about her because she's a phenomenal pain management specialist, and she's board certified in anesthesiology, pain medicine, and addiction medicine. So she's triple board certified. Wow. So not just not just one specialty, she decided to get three, and not just the minimum, she's board certified, which is amazing and rare for physicians. So she's a clinician in private practice in Bowie, Maryland, and she's an advocate for patients and empowers them to get the most from their relationship with their pain physician, as well as other doctors and healthcare providers. She works with patients to find small, practical changes in their daily lives that empower them to help better manage pain and improve their overall health. She has extensive management and experience in the treatment and management of acute and chronic pain, as well as the diagnosis and treatment of opioid use disorder. And in addition to all of those things that she does, helping patients with chronic pain and opioid use disorder, she's also a mom, and she has two boys and a German Shepherd, and she owns her own private practice. Wow, it's just amazing what you do and what you've been able to achieve in treating chronic pain and acute pain, because it's such an important topic, especially in this day and age. We've heard a lot about the opioid epidemic, and a lot of people live with chronic pain. Most of us have experienced pain at some point in our lives. So our target audience are mostly high achieving professionals. And our topic is how they can embrace more joy in their professional and personal lives. And there's a lot of high achieving professionals that are also living with chronic pain or maybe living with opioid use disorder as well. So it's just a pleasure to have you to
Thanks.
discuss this topic, Dr. Merritt.
Yeah, I'm glad to be here. And so many of those high achieving folks who may be interested may also be caregivers for others, right? We
Right.
may have family members, siblings, who knows, people with significant chronic pain. And if we don't have a pain problem ourselves, sometimes it can be difficult to relate to that person.
Mhm.
Um, it can be a tough place to be. And then I would say, too, I treat chronic pain and I see patients in pain every day. But there's folks, and we both know as clinicians, there's folks that treat patients with pain or go on a pain rotation. They're like, wow, I do not want to do that.
Right.
There's various reactions to it. And maybe if there's something I can share is somewhat, how you can work with patients with chronic pain while maybe insulating yourself to a certain degree.
Mhm. Yeah, I like that you said that, because we all know people, if we are not the only ones suffering, we may not be suffering personally with chronic pain, but we know people that in our
Sure.
lives that are suffering with chronic pain. And we can be more understanding and more helpful by having the knowledge that you are able to share with us. Yeah, definitely. And then as far as clinicians, we know that pain is a touchy subject for a lot of physicians and providers because of concerns about possibly prescribing medication that has side effects or that may be addictive, right? Because some of the pain medication is addictive. With that, there's a concern that you may be encouraging addiction or enabling addiction for a patient when treating their pain. And then there's also the concern that, well, I guess it's not necessarily a concern, but only the patient can feel the pain, right? It's not something that we can see. So
Right.
it's very subjective in terms of how we may interpret someone else's pain, right? We have to believe the patient about what they say.
Right.
And that can be complicated because there's no clinical finding as far as,
Mhm.
I see your arm is broken, so I'm going to give you pain medication, right?
Right,
But when the arm is not broken, there's no, fracture, but
right.
the person is in pain,
Well, and
it
I
can
would
be.
say that, we know now scientifically that all pain is experienced in the brain. And
Mhm,
so if you can kind of start to couch it that way in your own mind, then I think there's a lot of room for people to have their individual experience. And I don't need to negate anyone's personal experience that I'm not experiencing firsthand.
mhm,
But it is up to me to, you know, evaluate the patient, take into account their reports of pain. And yeah, that ultimately, and this is one of the challenges of pain management, we don't really have objective measures. And we just have to be okay with that and realize that, we have subjective measures of pain. We can have descriptors, we can have pain scores, we can talk about a patient's experience, but we just don't have objective measures for that.
mhm,
I think it makes me think just a little bit about an experience I had this week with a patient who was coming to see me for Botox.
mhm,
And Botox is a treatment for chronic migraine and for headaches. And the patient was saying, kind of what came out of her mouth was something along the lines of, I didn't really feel like this one lasted as well as the last one. Kind of some of these other ones, I feel like they've lasted longer. And I we've been treating, in addition to her face, some of her jaw where she has TMJ.
mhm,
And so we discussed, well, hey, if we're not getting the right outcome with your jaw, you do have a jaw specialist. It may be that it's better to work with him for that.
mhm,
And very, as we explored that and dug in a little further, and really out of like desire just to help this person, I start to say, well, hey, if you're not getting the right results, we might need to route you this other direction. And then as she kind of reflected on it and we talked, she's like, I'm so much better than I was. And it was interesting because she really came to a new place of understanding and a new reflection. And she really felt like, I'm just going to, we're going to do today's injection. We're going to see how this goes. I don't really feel like I need to move in the direction of any other treatment, but we'll keep that in mind. And, she really acknowledged, hey, I'm so much better than I was before I started this treatment.
mhm,
And I thought that was a really interesting shift. And I saw it happen, just live in the room this week from meh, like, I don't know if the relief was that good
mhm.
to I'm so much better.
Wow. Yeah, because her understanding of her pain and the time frame, like, she
Yeah.
was much better. Yeah, yeah. So it's that shift
Yeah.
in mindset as well.
Yeah, so
Um,
I think she was able to take exactly, I think she was able to take a different perspective and a bigger picture perspective and really, shift in her own mind and recognize, I am getting some improvements. My condition is not fully healed or resolved, but,
mhm,
I think I'm good and I'm making progress. And we, sort of agreed to continue to monitor.
mhm. With that being said, I know with my previous management, patients with chronic pain, I've seen patients with fibromyalgia or different chronic pain syndromes. It's talking to them, there is that discussion of we're trying to get the pain better. It may not go completely to zero, right? So it's that expectation of, wow, you're so much better, more functional than you were before. But it doesn't mean that you might necessarily get to a place where you have pain of zero or pain free, right? Um,
Correct.
mhm,
Yeah, and I think that expectation setting, right, is really kind of what you're saying, setting expectations. And likewise, I've kind of gotten to setting an expectation. Here's an example that I use a lot. If I'm talking to a patient who has some significant chronic pain, I prescribed this patient a lidocaine patch today.
mhm,
This probably some myofascial pain of the low back. She's
mhm,
probably also a candidate for something called a facet block for low back pain after trauma, and she's done physical therapy and all the right stuff. And she just hasn't been using much in the way of topicals. She prefers to avoid oral medication. She's not looking
mhm,
for a pill. She wants to know, what can I do other than this? And so, to your point about expectation setting, for prescribing a lidocaine patch for many patients, and particularly if they have rated their own pain as, severe or moderate to severe in nature, I'll tend to say, hey, I don't think this lidocaine patch is going to solve your whole problem.
mm,
However, I do think that it could help. And then depending, how deep we want to get into it, we might talk about you might get some circulating lidocaine levels in your whole system. There's some data that that's helpful. It's
Mhm.
certainly helpful for myofascial pain in any areas that are tender. And so often, on the one hand, as the words really matter in pain management, if you can't tell already on the gist of this conversation, but to, not like gaslight the patient and say like, put a lidocaine patch on, you'll be all better. There's probably more to it than that, right? That we want to incorporate multimodal strategies. And for patients that are in my clinic with significant problems that haven't resolved on their own, they're going to need those multimodal types of care. And a lidocaine patch might be a really legitimate, potentially helpful therapy, but also, again, to make sure that I don't come across to the patient where, they misread me like, oh my gosh, I've got this severe problem. And Dr. Merritt thinks that a lidocaine patch is going to fix my whole situation.
Mhm. Right. Right. So that expectation setting is so important. I
Yeah,
like that and of course, how you word things because it's that mindset is so important and the expectation that the patient has regarding your treatment plan. Wow. So, can you share, Dr. Merritt, about how you may incorporate small practical changes in daily life for patients that are managing chronic pain so that they can manage it better as far as maybe non pharmacological things that may also help with chronic pain that you've seen?
sure. Yeah, and it's very patient dependent. I mean, so many of my patients, it's very common if you have significant chronic pain to avoid movement or to be less active. And so a area of focus is often talking about how we can incorporate more activity. So,
Mhm,
small practical changes, it could be so many things. It might be a discussion of physical therapy if that is something the patient might be amenable to, might be able to, get to the appointments, might be able to engage with that. And sometimes if a patient has said, "Hey doc, I've tried PT, it didn't work," it may just be that they've had the wrong therapy,
mhm,
because there is, as someone who treats chronic pain, and if I can like overgeneralize, a lot of my patients, if they have had a chronic pain problem for a long time and they might be less active, like an orthopedic PT that's like kind of would like to be a personal trainer, but they're a physical therapist, is not going to be a fit for this person. This
mhm,
person is going to need to find someone who's really ready to engage on a long journey of gradual activity improvement, gradual changes to move the needle, so to speak.
mhm,
And so sometimes it's just that they've had the wrong physical therapy. So in terms of like finding a practical change, sometimes it's a referral to a right physical therapy.
mm,
There's great data for PT, but it's very different, right? So if I prescribe somebody pregabalin, that intervention is the same pill. Like whoever gets it, that
mhm,
intervention is the same pill. But physical therapy, it's not always the same intervention, right?
mm,
Like if
mhm,
unless, we get really serious about writing super specific exercises, super specific PT plans, it's
mhm,
very often not the same intervention. And so you just can't, you either have to, know that the folks that you're referring to, or be somewhat specific on the referral, and or engage with that patient and talk to them about, hey, we're going to work together to find you somebody that can, help you increase your capacity. So I would
mm,
say that would be one really common way that we work with patients to see if we can get them a bit more active.
mhm,
Sometimes we talk about diet also. I actually have a team member who's certified in functional medicine. And so sometimes there are patients that want to engage with that and talk about functional medicine approaches for pain.
mhm,
A lot of times that is results in some very different eating habits. And a lot of times the initial steps are actually some elimination diets. So actually to eliminate certain things from the diet for a period of time.
mm,
Again, this takes like a whole visit to even talk through what this
right,
is with the patient and get
mhm,
buy-in. And so this is why I have a team member who's legitimately very interested in this and good at it and certified. So for
mhm,
patients that want to engage with that, I love it and I'm happy to have them do it. I don't over assume that everybody wants to do that because it's a big deal. But we have seen patients have real improvements with
mhm.
those kinds of changes.
Yeah, well, that's very interesting because, I haven't heard much about diet changes and improvement in pain through what you're eating, or maybe something you're eating could cause more inflammation, we hear a lot about inflammatory diet, things like that.
Right. Oh, yeah.
But yes, that's definitely in the field of functional medicine. So it's good
Yeah.
that you have someone that is also looking at diet or other reasons for pain or other ways that may alleviate the patient's pain.
Right.
Yeah,
Yeah, and
so
there's definitely big data to suggest that, the standard American diet is very inflammatory, is
mhm,
associated with higher levels of chronic pain, particularly a Mediterranean type of diet, even without going down the functional medicine path, really just incorporating more olive oil, more healthy fats,
mhm, or
more
veggies.
vegetables, less red meat, doesn't have to be zero, can result in lower levels of inflammation and less pain. And for some patients, some weight loss is helpful. It doesn't even have to be like what I tend to tell people is like, look, you don't have to be a bikini model. Like, it's not that. It's really just, the person that their primary care doctor might want them to lose 50, I'd be happy with like 5 or 10. Just starting to move the needle is a big accomplishment often. And so I'll also tend to expectation setting, tell patients, hey, I don't think this is going to solve your whole problem, but you're
Mhm,
likely to feel a little better overall. And so then we just have to start somewhere with, moving the needle, getting some, types of changes for improved engagement in their health.
mhm. Yeah, so setting that realistic and achievable goal so that they can
Mm,
see that they've made an improvement and they'll be more encouraged to continue on.
yeah.
Yeah, I think that's very important. So, with that being said, what role would you say that the patient physician relationship plays in fostering a sense of joy and optimism for patients that are dealing with acute and chronic pain?
I think it can be really big. I mean, I do think that having a productive, positive relationship, definitely helps patients engage over the long term and, stay in care, et cetera. I think it is really important. And I do think, I've been in my practice for 8+ years. I do think it's a source of strength and,
Mhm,
support for some of my folks. I have a patient who's going through some prostate cancer treatment. And, he just sent me an update lately, the way that you send somebody an update that is interested,
mhm,
because he knew I was interested and I appreciated it. And frankly, I'm an anesthesiologist. I do pain management partly because I did not enjoy the like lack of long-term longitudinal relationships in the OR. Some
mhm.
people love that, like, wow, good, I never have to talk to you again. But for me, that was not the fit. And so pain management is better in that way because it's therapeutic, I think, right?
Yeah.
Like, this is the way that I was mentored and taught in medicine, that the therapeutic relationship. And
Mhm.
that's just part of the deal. I think there's also a breed of pain doctor that is maybe a block jockey that
Consultant, yeah.
wants to like poke people with needles.
Mhm,
Yeah. Or our hospital locally has like a bunch of radiologists that just like stick needles in people. And
mhm,
I think it's very lucrative, but like, what is it? It's a service. It's a
mhm,
needed service for
mhm.
diagnostic and treatment injections,
Right.
but the relationship is still with like the orthopedic or whoever,
Mhm,
sent them there. That's not, and they don't put themselves out as a pain clinic because they're not. So just a different thing. So there's
right.
types of doctors that, just provide this service or just want to only do injections. For me, like, that is part of our practice and something that we do, but it's not my only interest. It really because of this, because I realize that it's so important to have a real relationship with your patient. So I feel
Mhm,
like it can be really helpful. I mean, on the other hand, I would share an anecdote too, where obviously there are pre-existing factors in the patient
mhm.
that also determine outcome. So
Right,
it's not just like, "Oh, you get a great pain doctor, all your problems are solved," right?
right, right,
No, that's not the only thing that,
right.
for instance, I saw a patient this week who has had some significant chronic pain related to like Ehlers-Danlos hypermobility, and she's been in treatment for some years. And she's had some good success with trigger point injections that we've done for her recently. And she's just a giggly person. And like, I don't doubt that she's in pain, but if she's in the office, like, she's telling me a story, she's laughing at it, I'm laughing at it. She makes the whole thing very pleasant,
Mhm,
but yet I don't doubt that there's pain. And so
right.
this is like an interesting, and this is like just an inter-individual difference,
Mhm,
where you have someone who, frankly has like a pretty positive affect,
mhm,
who still has a significant amount of chronic pain.
mhm.
And I guess I bring that up in part because for you or members of the audience that aren't aware, there's a lot of data actually that like negative affect, so mood, anxiety, depression, etc. These things are hugely correlated with chronic pain,
Mm-hmm.
right? So people with chronic pain have way more depression than
Mm-hmm.
the average population, like twice as much. And then likewise, people with depression have way more chronic pain than average people.
Mm-hmm.
Right. And not that there aren't outliers, because there are, but, it's very often, and this has been observed and noted in the literature, that, frankly, there are just these like probably mood related contributions that can be challenging to work with.
Right, right, right. So they may need, more comprehensive teams, to help with the
Yeah.
depression, to
Right.
help,
Yeah. Is
the
your
other
mental
things,
health being optimized
anxiety.
with?
Right,
Hmm.
right. Because if some people may focus so much on that pain, that it can be like, right. So I know when one of us, I know first, sometimes when you're hurting, you're just like, oh, my back, my back, my back, my back, my back, my back. And if you just focus only on that pain, then you forget to, that pain may last, and you need
Hmm.
to also focus on life and things around you, and try to see the positive as well, and work on the pain improving, because sometimes that pain may not go completely away, but if it takes all of your focus, that can cause more anxiety, depression issues. But of course, it's more complex than that.
Hmm.
And having a team or looking for support, especially a lot of people with chronic pain have severe depression, and it's important to treat that as well, because I know it can also be associated with some suicidal ideation and suicidal thoughts when pain is not treated appropriately. So definitely having that patient physician relationship where you have someone that you can confide in regarding the pain and regarding those symptoms and feelings that you may have, that's supportive and that helps you, take small steps to improve, because it doesn't go away overnight. That's Pain is something that it can be difficult to treat. So yeah, it's definitely something that doesn't go away overnight. So, yeah, I like that you have such a comprehensive practice, and that the patient physician relationship is so important to you. And I see that when you talk about it, that you find joy in taking care of your patient and seeing them improve over time.
For sure.
And it's, not only the patient gets relief, but when patients are improving, following the plan, doing better, you as the physician, we as physicians also feel good, because that's our goal, is to help you improve and to try different methods to help the patients improve. The goal is not to just continue, sometimes certain people may say, oh, they just want to keep giving me a pill and the pill doesn't work, right? Or that's not the goal. The goal is
Hmm.
for the patients to have a better quality of life.
Yeah.
If the pill is important for that, or if certain treatment is important for that, that's the overall goal, is to improve the quality of life for the patient.
Yeah.
And
That's right.
yeah, and having that relationship is important.
And so often, if I have those conversations about, such and such medication isn't working, we just have a serious conversation about just stopping it, and
Mhm,
whether it's weaning potentially if it needs
mhm,
weaning, but, whether it's an opioid or Lyrica or what have you, if it's not working, you can have a sensible conversation with a patient where you say, on the one hand, we want to practice evidence based medicine. And well,
mhm,
patient, if you have fibromyalgia, you're supposed to take Lyrica because you're better off like not on an opioid. And this is a, evidence based recommendation.
mhm,
But and so I'll speak with a patient that may have been encouraged to continue a medication. And I think that's fair for, 3 or 12 months, really give some of these medications that take a while to make a difference, give them a
mhm,
nice long trial. But by the time I'm seeing a patient, very often, if that has been the case and they've had a nice long trial of a medication. And like I said, it could even be an opioid, well, if you don't feel like it's helping, then like, let's just stop doing this.
mhm. Right.
And I think it's actually more rare than we'd like to think it is that we really have those discussions.
Mhm, mhm. Yeah. Yeah, definitely. I agree with you. It's important to just have those discussions. So we have a wrap-up game,
Mm,
which usually it's an intro game, but sometimes it's a wrap-up game.
yeah.
Yeah, so it's called convergence. So on the count of three, you will say the first word that comes to your mind, and I'll say the first word that comes to my mind, and we'll see if we can say the same word. And if we don't say the same word, we'll find a word that connects the two. You ready?
Okay. Any word. There's no hints. There's
Any
no.
word, no hints, no game. Yeah, we just say the first word that comes to our mind after. Okay, you ready? So
Okay.
3, 2, 1.
Plant.
Friend. Friend and plant. Okay, plant and friend. Something that connects plant and friend together. Okay, you ready?
Okay.
Okay.
And now my next word is something that connects them.
Yes.
Okay.
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 All right. 3, 2, 1. Garden.
Nurture.
What did you say?
Nurture.
Nurture. Okay, nurture and garden, they kind of go well.
Oh,
So,
yeah. Mhm.
something that puts nurture and garden together.
Mm.
Mm, okay. 3, 2, 1. Seed.
Gardener.
Seed and gardener. Okay.
Mhm.
Seed and gardener. Something that puts seed and gardener together. Okay. 3, 2, 1. Flower. Ready?
So, like to put it in the ground.
So, okay. Yeah. Sow and flower.
Mm.
Okay. Sow and flower. 3, 2, 1. Roots. Yeah.
I don't know. I don't know. I didn't even have one.
Okay. No, is that the first word?
I'm
Yeah.
like, wait, what?
I said roots. Root, like a
That's a good
root.
one.
Yeah. It doesn't have to be good. It's just the first word that comes
Yeah.
up. Yeah. Nothing?
Leaf.
Leaf. Okay. Root and leaf. But we try to say at the same time so you don't hear my word because we
Yeah,
want to
yeah,
see.
yeah.
It's okay. So root and leaf, something that connects those two. 3, 2, 1.
Stem.
Growth. Stem?
Mhm.
Oh, okay. Stem and
I'm
growth.
being literal. They
Okay.
literally are
It's okay.
connected by a
It's
stem.
okay. There are. You're right.
Yeah. I
You're
mean,
right.
that was the easy answer to me.
That was easy. Yeah, I wasn't thinking too little. I was thinking about growth.
Yeah, no, see, that's good. You're more free brain.
You're free. All of the brains are good. So we'll see. So growth and STEM, try to connect those together.
Okay.
3, we can't repeat from the
Okay.
previous. 3, 2, 1. Bloom.
Branch.
Bloom and branch.
Mhm.
Okay.
That's pretty
Bloom,
good.
bloom and branch. So this is our last one. Bloom and branch. Something that connects bloom and branch together.
Mm.
Bloom and branch. Mm. Oh, goodness. Okay. 3, 2, 1. Earth.
Flower.
Earth and flower. I was thinking flower, but I didn't say flower. I
Oh,
think we had already said. Did we already say flower?
you did say flower. I didn't say
Oh,
flower.
okay. Okay.
You were
Yeah, because
trying to
I
hide
was
the
like,
heat.
I was thinking flower, but I feel
Yeah.
like we already said it. So the
Yeah.
earth. Yeah.
Okay.
So that was fun. So that's a game. Sometimes we're able to get like boom, same word. Sometimes not, but
Neat.
it's fun to just say the first word on your mind and try to connect the two. So with that being said, we'll do some of our wrap-up questions. This was a great interview, and I learned more about pain management and expectation setting and your practice, Dr. Merritt. So, but tell me, who is a model for joy in your life?
Oh gosh, probably my sister. Probably my sister.
And
She
why would
is
you
just
say that?
always someone who's maintained a positive attitude and in the face of adversity and just been a source of a lot of joy and fun and always able to find, the bright side or something light in what's going on.
Mm-hmm. That's great. And then if you were cooking a cake of joy, of course, theoretical cake, what would
Mhm.
your top 3 ingredients be and why?
Oh yeah, I think I have thought about that one. I think my cake of joy would be I think sunshine,
Mhm,
because I do enjoy a sunny day, hot or cold. Sunshine is wonderful.
mhm,
I love my dog.
mhm,
That is just pets are a wonderful thing. And my pet brings me a lot of joy, my German Shepherd.
mhm.
And I think movement, for me, I feel really good when I'm able to move my body and be active.
Yeah, it's very important. Those sound like great ingredients. The same ingredients that the flower blooming needs, right? They need the sunshine and a little movement, not
True.
too much movement, but they do need the sunshine. So, as we're wrapping up, I just want to share that you do have your private practice in Bowie, Maryland. So, if we do
Yeah.
have any listeners that are in the Maryland area or in near your location that and they're looking for a pain management specialist, how can they find you? Is it best to find your website
Yeah.
overall?
Yeah. You can find us online at lifestreamhealth.com.
Okay.
And there's a inquiry form online. You can send us a message. You can also call. The office is 301-860-0305. But yeah, send us an inquiry online or give us a call.
Mhm. And as far as our other listeners, if they want to learn more about, pain management or your service, they could also find you on Instagram, right? On your live stream HC and at Instagram. Also, you're on LinkedIn
Hmm.
at Sarah Merritt MD. You also have a YouTube channel and Twitter, Sarah Merritt MD.
Yes.
Um, Great. So it's wonderful to talk with you, Dr. Merritt. Sarah, it's been a great discussion.
Yeah.
And I think we all need to, I guess, an overall reminder from this talk is that, pain is something that all of us can live with in different ways, right? And also taking that time to think about people in our lives that may be dealing with chronic pain and
Hmm.
know that it's about expectation setting as far as with the treatments as for chronic pain and
Hmm.
taking time to realize that there's small practical changes that we all can make, especially people living with chronic pain can make to help manage that pain better. And having a good physician patient relationship is also key to improving chronic pain, right? So this was great. This is great. Thank you so much, Dr.
Thank you.
Merritt. We're going to wrap up. Please share this episode with a friend. Please like and subscribe and have a great rest of your day. Bye, everyone.